Hi there, I'm Phil Parker, retired physiotherapist from Auckland, New Zealand. The purpose of this video is to demonstrate a very gentle and pain-free technique for the treatment of acute lower back pain. These patients exhibited symptoms associated with the fourth and fifth lumbar segment with asymmetrical or unilateral pain extending into the buttock, thigh or lower leg. I developed this technique over many years in private practice, and I published a case study in the New Zealand Journal of Physiotherapy in 1999. It did stimulate some interest from my colleagues, and I presented this technique at a manual therapy conference. Patients suitable for this technique exhibited no abnormal bladder or bowel symptoms or signs of frank nerve compression or radiculopathy. Other patients excluded from this technique were those who exhibited a sciatic scoliosis or lateral shift. I recommend that this technique be carried out by a qualified manual therapist and not a layman in order to exclude sinister pathologies. The traction and mobilisation techniques are both performed with the patient painful side down, inside lying. Okay, so I've got the patient inside lying, painful side down. I'm going to just move the knees, move the hips, so we just get a little bit of increased lordosis. We notice we have a female patient, obviously has quite a wide pelvis, so the idea is to perform this technique with the spine in as horizontal plane as possible. So we're going to just pop a little back roll in here, just to straighten out the spine. You can see there's a little bit of a curve there. We pop this in here, and we've got fairly straight spine. So the traction technique, I'm going to be pushing with the heel of my hand, L4-5 level, and I'm going to be pushing from my hips, anterior superior iliac spine, in a horizontal direction. The aim is to keep to a totally horizontal plane, not to go vertical or a bit further down. So I'm going to tuck my hand in here and push very gently a 4-second traction and release. So it's just a sensation of taking up the slack in the tissues and then releasing. If there's any pain, if there's any exacerbation of symptoms from the patient, I would desist from doing that. In clinical practice, for the purposes of adhesion to the hand and patient comfort, I would use a little square of foam. So again, we just tuck it in there, stabilising her hips with my left hand and pushing horizontally. Doesn't look like much is happening, but often the patient will report a decrease in symptoms and the fact that it actually feels very comfortable. Alright, this is the second part of the technique. The patient is lying again on side lying with the little, in this case, with the little foam support to stabilise the spine and keep it in a straight line. So this procedure, I'm going to be pushing in a PA direction with my hand to mobilise the spinal segment at L4-5. I'm going to put my hand in this position. I'm going to be just nestling the lumbar spine in between my forefinger and thumb thus. I'm going to be pushing from here. A gentle 3 to 4 second PA mobilisation. In clinical practice, again, I will be using foam for patient comfort. Again, like this, tuck it in there, and I'm pushing from my hip, from my anterior superior iliac spine in a horizontal position. If the patient reports no discomfort, I would follow that up with another 5 to 6 traction mobilisations as demonstrated previously. I'm stabilising the hip with my left hand, again tractioning, taking up the slack and releasing. Following this technique, I will ask the patient to lie prone and perform extension in accordance with the McKenzie extension protocol. I find that the combination of the mobilisation, the traction and the extension makes the symptoms resolve much more quickly than without extension. The patient will go home with some advice to perform the extension exercise at home, maintain the lumbar lordosis and avoid sitting for prolonged periods. In conclusion, I'd just like to say a few pointers. This technique is not suitable for patients with central or symmetrical pain. The technique may push the symptoms off to one side. Generally, as a rule, I would put the patient painful side down. Occasionally I found people were more comfortable painful side up and side lying, and then once they were more comfortable lying prone, I would switch them to painful side down to continue the technique. Following a good result from the technique, I would get the patient to perform extension exercises of the lumbar spine in accordance with the McKenzie protocol. I found this was very helpful in resolving symptoms. The patient would go home with instructions to maintain the lumbar lordosis and use the extension exercise program. While traction and mobilisation are separate techniques, I believe that the combination of these is more than the sum of its parts. My theory is that the traction technique reduces an annular bulge in the disc wall. This is all hypothetical, but it does seem to work anecdotally. If you have any questions, I'd be very happy to answer them. Feel free to email me at the email address on this video. Thank you for watching.